So once again, I'd like to welcome everybody to this quarterly working group meeting. This is what we've been doing every quarter, and so another one is coming today. So before we go ahead, I ask that we quickly introduce ourselves, one after the other. Mention your name and the name of your facility. So we quickly do that because of our time. So we strictly follow the agenda. So can we have everyone introduce your name and your facility? Who wants to start?
Good evening. I'm Edianet Mokwede from Lutz. Thank you.
Next.
Hello.
Yeah, we can hear you. Please go ahead.
Everyone.
Good evening.
You're welcome. Next.
Good evening, everyone. Hello.
Yes.
Shall I go next? Shall I go next? Hello, everyone. I'm
Hello.
Kate. I'm Kate Steele from Shine in the UK, and working with Afolabi and Brenda, who's be joining us shortly. Afolabi, Brenda says she's waiting to be let in. Are you able to admit her to
Oh,
the meeting?
okay. All right. Thank you for. Yeah. Yes, it's coming in now. So can we have another person?
Good evening, everyone. I'm Janet Miwadigun from OATSC Ife.
Welcome.
Hello. Hello, can you hear me?
Yes.
Hello, good evening, everyone. I'm Ajayi Oladeolanike from University College Hospital, Ibadan.
Welcome, madam.
Thank you, sir.
Next.
Good evening, everyone. John Shomiwa from Festus Fajemelo Foundation. Thank you.
Welcome.
Good evening, everyone.
Good evening.
I'm Miwadigun Janet from OATSC Ife.
Welcome.
Good evening, everyone. I'm Lara Fernandez, and I'm a volunteer with Festus Fajemelo Foundation.
Welcome.
Good to see everyone.
Welcome.
Thank you. Hello, Kate.
Thank you.
Yes, introduction. Is there anyone here who has not introduced?
Good evening, everyone. I'm Abimbola Komolafe from FFF Foundation.
Welcome. I think Brenda is here. Brenda, can you, let's have you speak.
Hello, everyone. Yeah, I'm Brenda Chia from the UK and from Shine, and it's nice to see some familiar faces again, and also some people that I have not met before.
You're welcome, Brenda.
Thank you.
And thanks for being together the other day. Thanks for your time.
Absolutely. It was lovely to see you in real life, Afolabi.
I'm back in Nigeria.
I hope you had a safe journey home.
Yes, thank you. All right, I think we can start off. If there's any other person who hasn't introduced, probably without have that one as the meeting progresses.
Can you hear me?
Yeah, we can hear you. All right, thank you very much, everybody. So I've just shared I'm projecting on the screen the agenda. So we've had an introduction, the opening remarks, then we have quick update from the various facilities. Please try and stay within the time. I know that each facility is still going to submit written reports. So we just want to have a summary of updates from your facility. Then we're going to have the overview of the new grants, which I'll be sharing in a few minutes. Then we'll have general remarks by the CEO, Shine UK, in person of Kate Steele. Then Brenda will be talking to us directly to the nurses of the expectations on the new grants. Then we have responses and questions, then we wrap up. So once again, I want to welcome everybody, especially the CEO, Shine UK, Kate Steele, and our specialist continence nurse, Brenda Chair, for taking time to be with us this evening. I also want to welcome esteemed nurses from various facilities who have been working tirelessly to ensure that children with spinal bifida and hydrocephalus receive the best of supports, especially regarding continence care management. So without wasting much of our time, so we shall be calling for updates from facilities that we have been working with. I've said 5 minutes here, but if you spend less than that, I'll be happy. So can we have the first facility to present their report? Let me call on OAUTHC to present their report. Thank you.
Good evening, everyone.
Good evening.
Good evening.
I am Janet Miwadigun from OATSC. I'll be taking the report on behalf of OATSC. First of all, I would like to appreciate Mr. Fajemilo, the FFF, Shine, and International Federation of Hydrocephalus and Spinal Bifida, on behalf of our patients and family, for everything we have been doing and everything they have done for them. Hospital labs, and especially on behalf of our HOD of our neurosurgery department in OATSC, for everything you have been doing for us. So I'll go straight into my update now. First of all, I would like us to know that in OATSC, we have in our department, we have a room set aside by the help of our Professor Komolafe, where we run our clinic. and give us an avenue for privacy and to attend to our patients effectively. So we say kudos to our professor on that provision. So I would like to say what has been going on in our clinic presently from our last report. We have old patients who experiences results and good effects from CIC. We would say we have almost 100% of old patients who have been enjoying CIC and have seen results. However, we have of them that complain of not from bowel washout. The estimate of a patient from the last meeting till now, mostly newborns. They were either the one giving birth in our facility or being referred from other facility to us who undergo surgery. And so after the surgery, we intimate them about CIC, and we inform them about the training, about bowel washout, about the foundation, about all the support that has been on ground to help them. And so we always ask them to come back. As they come for clinic, we see them on a routine, and then we involve them to commence, and we encourage them to commence CIC earlier, as it will be of great benefit to them. Recently, in March 14, 2022, we had a support group by Mr. Fajemilo, which also gave us a venue to see our mothers, the mother of our patients, en masse. So at the support group, we gave them encouragement to continue CIC and bowel washout. And we are grateful that the children are doing so well. And the support group has also provided a venue for us to see them en masse. And as I've said earlier, newborns in the hospital are referred to us who are hydrocephalus or spinal bifida are intimated about CIC immediately after the surgery. Departments, especially from pediatric surgical and children emergency clinics, as we have earlier informed their nurses that these particular patients should be referred to us immediately. Furthermore, I'll be going into, okay, and also
you have 2 minutes left. You have 2 minutes left.
All right, thank you. Thank you, I'm running up now. Our head of department also refer patients to us as they walk outside the hospital premises. So apparently our clinic are run by nurses. So the surgeon, Brother Komolafe, always refer patients to us. Immediately they find such patients. Now going to our challenges. We don't have too much different challenges from the one we discussed the last meeting. The first one being that we are short-staffed. And being short-staffed is even much more right now, as most nurses from the facility are traveling out of the country. And the other challenge is the long distance. Although Ife is not as that big as Lagos, but the surroundings towns around, movements to and fro to a facility can be a challenge as part of availability of a transportation system and finances. So based on this, some stop coming to clinic, and a couple with the fact that some complain of not seeing effect. And so we give them encouragement, to encourage them to continue and not to stop. So these are my updates. I would also like to appreciate Mr. Fajemilo, Brenda, Kate, and all the other nurses on this forum for listening. Thank you.
Thank you very much, Ms. Adikun, for that presentation. And I want to commend the team at OUTHC for doing great work. So that's very encouraging. and we are glad to hear the progress being made. So, as well as sharing the challenges, so which we, of course, we better inform us on areas where we need to intervene and address. So, I would like to call on Ruth to please present your report.
Afolabi, just before the next report, is it possible to just ask a couple of small questions to the previous speaker, please?
Okay, that's good. That's good.
If that's okay.
Yeah.
Thank you. And Janet, may I call you Janet?
Yes.
Excellent, thank you. Can I just ask you about roughly how many children do you have on your caseload? I know you said that you have more children that you have seen new referrals, but how many total?
From the last meeting to now, we have few children, about 4, and mostly they are newborns. And we have one female and 3 boys.
And how many? And so 4 new ones. And how many children do you expect to see? How many children have you seen in total? And that you expect to see repeatedly, presumably?
Okay. We have a record book. I'm not in the. I don't have access to it.
Don't worry. Don't worry.
Yes.
Do you know roughly, Janet? I mean, is it roughly 10 children, roughly 20, roughly 50?
Roughly, we have about 30 children.
About
Roughly,
30.
Yeah.
That's useful. Thank you. And may I ask you just one more question?
Okay.
You know, you said that you're seeing a good 100% of good effect from the bowel washout, which is excellent. Well done. And you said that some are seeing good effects from the catheters, but a few see no real difference. Is that just from catheters, or are these children who are receiving oxybutynin as well?
I didn't get that. I didn't get the last part of the question.
Okay, and is it? Have you been able to do bladder pressure measurements on the children who are catheterizing and start oxybutynin medication, or is it just catheters at the moment?
We have some children that came up with issue of from CIC. We have done bladder measurements for them. We have done it for them. So we do based on assessment of the children. So
Excellent. And have you had a supply of oxybutynin now?
Yes. I'm sorry. I'm supposed to have mentioned that during our last support group, Mr. Fajemilo brought us butylene for us in our clinic.
Yeah.
Yes.
Yeah, and because I was just thinking that the children who see no benefit from catheters, is it because they need oxybutynin as well? But maybe now you've got oxybutynin again, maybe they will see some benefit too.
Yes. Thank you, ma'am.
Yeah, no, thank you, Janet. That's really useful. Thank you.
All right. Thank you, Brenda.
Thank you. Shall we go to Luth now, Afolabi?
Okay, thank you, Brenda. So can we have Lutz?
Good afternoon, everyone.
Hello.
Hello, good afternoon.
We can hear you.
Good afternoon, everyone.
We can hear you. Go ahead.
Good afternoon.
Okay. Good afternoon. This is a report from Lutz facilities. Firstly, I want to thank Mr. Afolabi Fajemilo for his effort and for his enthusiasm towards the children with spinal bifida and hydrocephalus, and Kate and Brenda and all over continent nurses all over the world. So this is my report. The continent management in Lagos University Teaching Nurse.
You've just muted, Tolu. Tolly, you are muted at the moment.
Okay, can you hear me now?
Yes.
The continence management in Lagos University Teaching Hospital takes place in the pediatric outpatient, that's POP clinic, first and third Thursday of every month, in collaboration with pediatric nephrology units under Dr. Esesobo, who is the consultant pediatric nephrologist. We see children with neuropathic bladder, spinal bifida, and hydrocephalus. The clinic has been functioning actively, at least 2 to 3 patients per clinic. We have nurses on ground and doctors on ground too. From the quarterly workshop meeting till date, we have about 10 new patients, and most of them were referred from pediatrics, neurosurgery clinic, children emergency, and some from orphanage homes. Then Continence Clinic is part of the clinic, is part of the nephrology clinic. So when they bring the letter, the referral letter, the doctors see and write some investigations like KUB ultrascan. They do urinalysis, they do urine FCS in case if they are detecting there is urinary infection. The KUB ultrascan is to know the anatomy of the kidney. Then the routine urinalysis MCA to detect if there's any urinary tract infection. And we nurses will demonstrate the bladder pressure measurements. So far, so good. We have adequate supplies of different sizes of catheters from size 6 to size 16. We have cones for bowel washout available, and we have oxybutyllin, which is also available. Most patients has been coming to collect their catheter, and there has been a good result. So on the 20th April of this month, there was a ground round by the doctors on their virtual meeting. They discussed about management of neuropathic bladder, and we nurses, continent nurses in LUT, we are also in attendance. We have like 48 participants, and DDNS OJ gave a lecture on continent management and bladder pressure measurements She talked about it during the doctor's ground round, and it was very comprehensive and highly appreciated by everyone. And people see the need for continent management for the children. So we want to talk about the feedback from our patients. We have like 4 to 5 or 6 patients that said good, that the mother said that the CIC has been effective and it has improved the health of the child. We have a child name CO, age 5 years, sex male, care, CIC and bowel washout. The father acknowledged that there was a reduced diaper use and had bed sore, but now there is wound healing. The child diaper rash has gone completely, and the child has a good self-image. So we have another child that the mother acknowledged that the bowel washout has helped the child empty the bladder, the bowel completely. There is a less use of diaper, and the child feels refreshed and clean. Another mother also testified that she acknowledged the child is not having the urge to urinate. There was a less use of diaper. The child always feels refreshed and have a sense of belonging. Then also, we also have a child named CO, that the mother testified that the child is not having self-confidence because the child frequent use of diaper has reduced due to constant CIC and bowel washout. So our challenge is so we go to shortage of manpower. We need more staff in continent management because some of the nurses that we have trained were deployed to another unit, and there's increased load to nurses that are available. Then to our clients and carer, to some of our clients, there's a burden to them, especially children with spinal bifida who require lifting or wheelchair, that they express discomfort and they default from the clinic due to financial constraint and distance from the hospital. Some caregivers and mothers complain of lack of transportation fare and distance to the hospital, which is a burden to them. Also, we have some care and clients that may need psychological, therapy or like an advice, because the care of a spinal bifida patient is long-term and there's continual use of catheter. So we need to always reassure them. So most of them are always reassured and giving psychological support. So the way forward, staff should be encouraged to continue the constant management care. We have some nurses, as we said earlier, that they were deployed to another clinic or unit and they were trained. And nurses should have a slot in our CPDC, continual professional development, which we do every Wednesday. Is a unit, is an educative unit in Luke.
1 minute more, 1 minute.
Okay, it's an educative unit in nursing services in Luke, where we discuss programs and topics. So we are waiting for our slot to discuss in May. They've given us a slot in May by the CPDC, Continued Professional Development Committee, to come and teach people, to enlighten people on CIC management. So also we also need for follow-up, because some of the patients, we need to call them, come and collect your catheter. Are you not coming to collect? We have to use our credit to call them, most of them, but we have to just sacrifice that. So to keep in a hospital appointment and to give them psychological support and to reassure them, because we know that this management is long-term. It's a long-term therapy. Thank you all for listening. I want to appreciate Kate Steele, CEO Shine, and brothers, specialists in continence management in UK, and Mr. Fajemilo for piloting the continence management in Nigeria. And also want to appreciate pediatric nephrology unit under Dr. Esisobo for taking a bold step to constitute the continence management in his nephrology clinic. May the good God bless all the continence management nurses home and abroad. Thank you.
Thank you very much for that report. Especially.
May I ask the same question?
Yeah. I was going to allow that, Brenda,
Thank you, Afolabi.
Just to commend the team in Luke for for the wonderful work that's ongoing, especially for sharing the continence management knowledge within a wider members of professionals, healthcare professionals. So over to you, Brenda, for your question.
Thank you. Could I just ask the same question about numbers? I know you said that since the last quarterly meeting, you had about 10 new patients. How many does that make altogether? How many children do you expect to be returning to clinic to collect catheters and oxybutynin, etc.?
And with the new patients and the ones that have been coming for the clinic for follow-up, we are expecting like 25.
Yeah. Thank you.
Hello. Can I add to what she has said? Unfortunately, we lost one of our patients, Victor, due to sepsis and severe bed sore. There was nobody to care for him since he lost the parents. He was left with only a sister who was recently married, and the care fell on the grandpa, who was not able to take care of himself, talk less of taking care of a child that is immobile with such complications. So we lost him. Last month too, we had Daniel on admission. He had sepsis, anemia, with bed sore. He was treated on my ward and discharged home, and he's doing well.
Was that Daniel? Did you say, Mrs. OJ?
Daniel. One of our, yes.
Yeah, the older boy. Yeah.
It's the older boy.
Yeah, but he's okay now.
It's okay. He has been treated and discharged.
Good. Thank you.
And any other question?
I think that's all for now. Thank you, Afolabi.
Okay, thank you. So can we have UCH present their report?
Good afternoon, everyone. I'm ADN Olariwaju from UCH. Can you please hear?
Good afternoon.
Good afternoon,
You can
ma'am.
go ahead.
Good afternoon. I'm ADN Olariwaju from UCH. I want to use this medium to thank Mr. Fajemilo and the management of FF Foundation for how they have helped us in UCH in introducing us to the how our spinal bifida
May I interrupt? I can't hear you very well.
December,
hello, Mrs.
we were
Olariwaju.
trained by Mr. Fajemilo and the OJ from UCH. We were introduced how to care for their bladder, bowel, and how to do the bladder pressure measurement. And after we were given some. Yes, sir. Hello, sir.
Okay, you can go ahead. And I think it's a network problem, but I think we started hearing you when, so you can go ahead. Speak on, ma. Speak on. You are muted. You are muted at the moment. Can you unmute yourself? Hello, Mrs. Olariwaju. Please unmute here.
Good afternoon.
Yes.
Okay, I've done that. Can you hear me, please? Okay.
Maybe
so
keep,
speak on.
Maybe keep your camera off because the connection is poor. If you turn the camera off, we'll hear you better. Thank you. It is nice to see you, but I think we hear you better.
Okay. Thank you, ma'am. So in January, we were given some items by Mr. Fajemilo. So some of the items given to us. And in UCH, we have the clinic. The clinic is normally run on Wednesday by the neurosurgery people. So that is the time we are able to see our patients. And be that the people that were trained, we are on the ward, we are in Northwest too. Because of that, we are not working in the clinic. So we use the opportunity to train the people in the clinic so that they too can know how to take care of this patient whenever they have their clinic. And while the people on the ward, while on admission, we on the nurses on the ward can take care of them. And because of the shortage, it's not possible for those on the ward to go to the clinic to give the to do the procedure for them. And that is why we want the people in the clinic to know about it. And by the help of our director, we are even planning in our nursing, our update that we used to have, the study day that we normally have every year, to inculcate the teaching during it so that everybody working in emergency, outpatient department, and in the neuroscience can know about it. So that is what we are planning, that all the nurses working in this can have the lecture and they can know it. So in case if they are being posted to that place, they will be able to give the adequate nursing care so that it won't be that the people that are working here presently on the ward and the clinic that knows how to do it. That is one thing. And so far, since we've started, about 5 patients have been seen and they have been coming to the clinic, which we have been able to teach them how to do the clean intermittent CIC. Then likewise, the bowel washout and the bladder pressure measurement. At least about 4 of them, they had a bladder pressure measurement done and it's within normal range. And likewise, we have the newborn, like about 4 of them that were admitted, right, like a 5 days, 6 days of life and had the surgery done. And because of that, we'll think that we cannot start immediately because they are still young, and I have to discuss with Mr. Fajemilo concerning it, which he said we should start as soon as possible. So all these patients have been discharged and we've contacted them that they should come after in the next 2 weeks so that they can start the procedure on time. And the one that we have been doing, we have been receiving the feedback that it helps them. Like the one that was the style, the Sharon that we used during the practical experience, at least the girl have been doing far. So far, there have not been any hyperthermia, because while it was an admission before we started this, it was having hyperthermia, but immediately we commenced it, the hyperthermia resolved, and since then the hyperthermia, she's doing fine, she's eating the normal diet, and looking at her physically, we can see the girl is improving. Likewise, we have the old patient that have been known before we joined the ward, and some of them came. There was one that even went to Ile-Ife, Obafemi Awolowo, being referred by one of our nurses that was trained, because we didn't have the facility. So she went there, I think it was 2 months ago, to collect the catheter. But later she was referred that since we have started here, that she should come over here for the catheter. So she came like on the 25th of this month for the catheter. I gave her one catheter. Then later I asked her that she should come on Wednesday, which was the last Wednesday, so that we can do the bladder measurement. And the girl is 12-year-old, and she's in DSS 3, and she's really doing fine. So the bladder measurement was done, and the child was even trained, because the mother has been the one doing the CNS for her, but we made her realize that she needs to know how to do it, so that she'll be able to do it on her own, and she can take good care of herself. So she was taught how to do it, and the bladder pressure measurement was done, and it was within normally. Although the woman asked a question that being that the girl is 12 years old, that she must start menstruating, that how will she cope? So we have to explain how she can do it and how she can cope with it, that it doesn't disturb her, that even if she knows how to do it, she'll be able to manage herself well. And she was counseled on personal hygiene, and she was reassured. So presently, we have about the total number of like 12 patients that have been seen so far. Although we lost one, the boy died last week due to overwhelming sepsis. You know, he has a lot of complications, and because of that, we lost the boy while he was on admission. The boy was admitted last year, November. Then series of things happened, you know, he developed hydrocephalus after the surgery. They were even planning to do ventriculoperitoneal shunt, but because of the sepsis, they couldn't do it. Eventually, we lost the boy last week. But so far, that has been the only death that we recorded so far. So we want to use this opportunity, at least we have been able to put smiles and a better life on the face of our patient. And we have been able to reassure the mother that there is hope for this patient, that they can still live, and they can still live a normal life. Although there may be deficit, but they can still live. They can still live beyond what they think of. And the challenges that we have challenges. The challenges is based upon our the number of staff. You know, everywhere there's shortage of staff, and because of that, we don't really have enough staff to give the adequate care. And that is the reason why we want everybody working in emergency, the children outpatient department and the neuroscience unit to know about this, so that if they are posted there, they will have the knowledge of how to take care of this. And likewise, the financial problem. Most of these patients have financial problem because they are spending a lot on the care of this patient. And some of them may not really have substantial finance to cater for this. So, but there was a time I discussed with Mr. Fajemilo about it, and they said, well, they can train them on what to do for daily living to make money. But with the situation on ground now, that the foundation is not really giving out any financial or money to them. Then the psychological something. You know, when you give out to a baby and you find that the baby has a spinal bifida, it demoralizes them. So we try to boost their morale by encouraging them that they shouldn't give up, that there is still hope for them. So all this, like today, I call some of them that we are expecting them for their clinic on the, because but next week, Wednesday is a public holiday, that they should come on the upper week, so that there are some things that we need to put them through, especially those ones that were discharged after the surgery, they are still less than 1 month. So those are the things that we have been able to do so far in UCH. You know, we are just coming up, and we pray as we are going on, even our doctors and nurses with more training and everything, and more people, as more people are coming, we know we will need more things. about more things that we need to use. So I want to thank the foundation, and I want to thank the people from UK for the support they have given to us to make life in Nigeria a better life for our people to live. Thank you very much.
Thank you very much, Mrs. Olarewaju. I deliberately gave you additional time because you're just coming on board, and we are glad to hear the good reports happening at UCH, and the number of patients within that space of time. Although we commiserate with the family of the child that lost. So pray that God give them the gratitude to bear the loss. So, however, it's been a good report, and I want to really commend your team for the enthusiasm you have brought into the program. So, as the partnership progresses, then we hope that we're going to have a lot to do more. So, Brenda, do you have a quick question for UCH?
The only question is, I know it is recent that since you have started, but how long since you started your program?
We were trained in December, so we started in January.
Okay, excellent. And in that time you have got 12 patients catheterizing.
Yes, ma'am.
You have done very well, haven't you? Well done.
Thank you, Ma.
No, thank you. Yeah, lovely. Thank you very much. That's all.
So, Brenda, are you done? Oh, all right. So we still have time for comments and questions from the reports we have listened to, but let me just go ahead with the come back to the agenda, and I'll be sharing with us overview of the new grants. Permit me to share this PowerPoint. So, please, can we have everybody? Can you mute?
Can you mute again?
Okay, let me do that. Okay, so we have a new grant for the project. The project title still remains, and that's Saving Lives, Improving Futures. So, and what's the description? So, we're saying that the project will benefit at least 250 children and young people with spinal bifida and hydrocephalus and their families in 3 regions of the country, Southwest, where we are currently operating, and we'll be scaling up to the Northwest and South-South, all to improve the health and futures through improved continence care and management. And what's our goal? Our goal is to save lives and improve life of these children who live with spinal bifida and hydrocephalus. So, so which strategies are we using to achieve these goals? One, we hope to reestablish continuity of care and management for almost, about 100 children and young stars whom we have been seeing since 2017 to date. So we hope to continue with them, and also to bring in new patients to reach about additional 150 children. So we have a target of 250, at least 250 children with spinal bifida and hydrocephalus. We intend to empower 60 healthcare professionals across 6 public health facilities and continence care management knowledge, as well as COVID-19 preventive knowledge and skills. As we all know that, since COVID struck, we've had to, it has impacted various sectors, including the health sector. And as we continue to provide care, continence management care for these children, we want them to be safe. So we're going to be running a, one-day training for all our nurses to, have a knowledge of prevention of COVID-19 as they provide care for these children. We'll be promoting and supporting 6 public health facilities. Some of them we've started, so we'll reestablish them. And like I did mention, we're going to be scaling up to the Northwest and South-South. So we're going to be having additional facilities working with us. We'll be providing supplies of vital continence management equipment, including medication to at least 250 children. Talking about catheters, cones, oxybutynin, etc. We also be sustaining and improving access to FFF's own continence care clinic, which we started purposely to serve as a backup to public health facilities, especially in times of industrial action, as well as occasions like COVID-19. If we have that situation again, then where patients cannot access hospital and facility, then the clinic has to provide serve as a backup. So I did shared with you sometimes that what actually brought about this program in Nigeria is as a result of incident we have with a child called, Gabriel. So who had, bladder retention for a few days and was going through complications. So, and incidentally, I was with Kate in her office in Peterborough that day, and sharing that information with her, she became worried. And the following week, she took us to Wales. So where we started the discussion about starting this program in Nigeria. So FFF clinic will be, serving as a backup. Then we'll be providing outreach support to at least 50 children. So out of these 250 children, will be, monitoring them up to where they live to ensure that they know the importance of continence care management and to ensure that they are following the protocol as they are taught. So what are the outcomes? We have about 6 or 7 outcomes. One, that we are going to reach out to 250 babies and children with spinal bifida and encephalus to ensure that they have improved continence management and care, so that we are able to impact positively in their lives in terms of physical, emotional well-being, enhance their social, life, and to ensure that they are able to participate in their, things like education and family life. So outcome 2, we'll be empowering 60 healthcare professionals in 6 public health facilities, so that they acquire knowledge and expertise in continence care management. Outcome 3, we have to empower 250 children and young people to gain advocacy and self-advocacy skills, increase social integration and reduce isolation, new perspective, confidence, and increase their self-esteem. Outcome 4, children and young people affected by spinal bifida and encephalus in Nigeria become part of the community and feel less alone in facing the challenges of raising a child with spinal bifida. Outcome 5, through the FFF works to resurrect their clinics, and I did mention that we'll be strengthening the FFF clinics to across regions and able to increase capacity and infrastructure required to increase long-term support for spinal bifida and naturals across Nigeria. Outcome 6. We hope that through this work, through this program, at least 20 Shine Kumru members living with spinal bifida and naturals in Wales, have gain insights into, the lives of people with same condition in Nigeria. That is, we have the knowledge, exchange, and we have the opportunity to engage in the project. Outcome 7, additionally, 20 board members, staff, volunteers of FFF, we have more knowledge of continence management challenges of affected children and partnership work between Nigeria and Wales. We're talking about FFF and Shine. So beneficiaries. So 250 children and young persons with spinal bifida will benefit directly, and 60 healthcare professionals, talking about youth and nurses. We have increased or strengthened capacity in continence management care. 6 public hospitals supported to offer comprehensive continence management provision. At least 20 Shine Kumru staff and members who have more knowledge and awareness of lives and challenges of people with spinal bifida and naturals in Nigeria, and the difference that Shine Kumru is helping to make. Other beneficiaries. So other charities in Wales, we also learn about these projects. That we have opportunity of knowing what families in African countries are going through. Then our donors, Wales for Africa, West Government, and West Council for Voluntary Action, through this project, we also understand the difference. The grants and their support they have given to us is making in the life of children with spinal bifida and naturals in Nigeria. Then 20 board members, staff, and volunteers of FFM who have more knowledge of bladder and bowel incontinence and are aware of partnership and knowledge exchange between Nigeria and Wales. So what are the deliverables? So the project has a project officer. Abimbola is on the platform. She's introduced herself. So project officers report, then reports from various facilities. So you know that right now that we all have roles and responsibilities. So case stories, we encourage, we expect that, the facilities nurses will be sharing, case stories with us. So our donor will be interested in knowing this. Then the continence group, working group reports. So project steering group, we have Kate Steele, the CEO and directorate lead with Shine, is the project lead. My humble self, the foundation director and project lead in Nigeria. Mrs. OJ is lead continence nurse in Nigeria. Brenda Chair, the pediatric specialty continence nurse, Wales, and Abimbola is FFF project officer. So roles and responsibilities. Christine, who is the CEO of Shine, is the project lead and responsible to our donor organizations. My humble self, I'm coordinating the program in Nigeria. Mrs. OJ is the lead continence nurse in Nigeria. And we cooperate with Brenda to ensure that there's design and delivery of training for other healthcare professionals and to develop a system for ongoing monitoring and support. Brenda Chell is the lead specialty continence nurse from Wales, and she will be working with Mrs. OJ to jointly deliver training, develop resources for other healthcare professionals. So the project officer will be reaching out to all of you, co-coordinate project activity, liaise with participating health facilities and healthcare professionals, and numbers for support for setting up clinics. Delivering outreach work, organize meeting and outreach work, collect and collate data. So that's the role of the project officer. Then participating healthcare professionals. So all of you working out from various facilities, you will be trained and supported to run clinics, but also establish outreach services where appropriate. So I'll be providing more information about that under EOB, how we are going to support you to be able to do the outreach work. The Continence Working Group, just like we are here, so it's a platform for all of us to, for professionals to share best practices, peer-to-peer mentoring, sharing knowledge, and challenges, and find a common way to overcome challenge, identifying issues. So other partners in the project, we have the International Federation for Spinal Bifida and Encephalus. We'll be using some of their resources, like protocol and other work, work they have been doing in other parts of the African countries. Then we have Child Help International. They will also be supporting with equipment and medication. So thank you very much. So that's the overview of the new grants, and I will be calling on Kate to please talk to us on the new grants. Thank you.
Thank you, Afolabi. I won't keep everybody very long because I know that we've got quite a lot to get through on the agenda. But I think one of the things I just wanted to say really about the project is that so often we take for granted what good continence care is, good continence management. And, you know, if we don't have continence problems ourselves, we don't realise what a difference that can make to people's lives when they are clean and able to manage their bladder and their bowels. Today, throughout the meeting, you've been continually thanking me for being part of throughout the project. Today you've been continually thanking me for being
Kate, you've muted again.
Yeah, no, I don't know, I keep muting for some reason. I'm not pressing anything. Anyway, yeah, so you've thanked me several times throughout the meeting for being part of the project, but actually it's not me who is the expert. I'm quite good at trying to get some money in and trying to get partners to be involved in things, but I really don't have the background in continence. All I know is the difference that I've seen you make, and Brenda and other staff in England, Wales and Northern Ireland by supporting and advising families and children about the improving continence care. We're very lucky. So for a number of years now, we have had some funding. I think we have had 3 lots of funding from the Wales Africa Hub, which is what Afolabi mentioned. And that's a Welsh Government initiative, and they offer a variety of programmes and funding and mentoring projects to different parts of Africa, and they're very keen to support and build links with African countries. So, you know, we're really lucky to have got some money again this year to be able to hopefully support you in the work that you're doing. And already just today, some of the reports that you've given, you know, obviously we've heard about some of the children who have sadly lost their lives, but also we've heard about the positive things, and that just working with these children, it's not only improving their continence, but their well-being and their confidence is improving. So I'm really pleased that we're working together. We are very lucky to have two experts with Brenda and Mrs. OJ who are supporting the project. I think there's a lot that everybody can learn. But just really thank you to all of you for being part of the project and giving your time to help make a difference to the children with spina bifida and hydrocephalus. That's it. Afolabi, is there anything else you want me to say?
Yeah, thank you very much, Kate. Yeah, that's very encouraging. And so the nurses have heard from you. That's our project lead. And Kate has been doing a lot since 2015 that we started this conversation about this program. And I actually told you that the incident happened in our office, and the following week she took us to Wales, and that was when, since then, she's been doing a lot to ensure that this program continues to run. And during our meeting last week in Cardiff, a lot was also discussed, and more effort has been made to ensure that even after the current grants went up there, the project continues. So may I call on Brenda to let us know expectations from various facilities, nurses, healthcare professionals in this program, so that at the end of the day, we are able to deliver what we have promised to our donors, because money was given and that's to be spent wisely, and we must achieve results. So over to you, Brenda. Thank you.
Thank you, Afolabi. First of all, I would like to congratulate everyone, because I think it's what we've been hearing is very positive, because all of you have got many children that you have taught and you've made a difference to their lives. But I think the other thing which I'm really impressed with is that you've clearly been cascading the information. You've been passing on the information to colleagues within the hospitals to try and make as many people as possible aware of the continence care management and techniques, and that to have got as far as you have despite the pandemic, I think is really very encouraging. So well done, everyone. And the next stage, as Afolabi said, is that we need to start collecting more data. So it's essential that we have some accurate numbers, not only of how many children we have, but that we have the figures on demonstrating the difference that the continence management makes. So in order to do that, then we have to work together to establish ways of collecting data. So I'm going to show you a couple of forms. Oh, actually, Afolabi, can you make me a co-host so I can share my screen, please? But we need to be clear on the reasons why we need to collect data. So one of them is so for all of us working within the project, all of us in Wales, in Nigeria, everywhere, in order that we can demonstrate the difference that we are making. I think it's very important that in order to make positive steps, we know we don't only have good feedback where parents are telling us that it has made a difference, but we can say so in numbers and prove the difference that we're making to children's health. So that's one reason. Another reason, as Afolabi has already said, is that we must respond to the project, where the money comes from. We've got to show them what we've done with the money. That's a requirement. So we have to have good ways to collect data. But also the third reason is for future funding. We would like to think that we're not only having funding now, but we can keep this project going and grow this project. So in order to make applications for new funding in the future, we must have data so we can say, if you give us this much money, this is exactly the number of children's lives we can change. So we need to ask you to record data really very effectively. the first way that we need to do that is I would like to ask you if you're still using that some of the forms that we shared with you right at the beginning, people who came to my second visit to Nigeria, my second visit to Lagos in 2017. We shared lots of information with you on memory sticks, and one of the charts that we used was this one. I hope everybody can see this chart on the screen at the moment. So I'm going to just and as you will if you've seen it, you know that there's day 1, day 2, day 3. They're all the same, but to make sure that we try and collect 3 days worth of information. So this is the chart that we should be asking families to fill in at home, so we can see how much their child is drinking, how much urine is coming out if they pass urine normally, how much urine is coming out with the catheter, how wet they are, and what their bowels are doing. So could we just find out if you could, you could probably use the raise hand or thumbs up, one of your reactions, if you can, or just unmute and tell me if that form is familiar to you. Are you using that one at the moment? Can we have an answer from everybody? Or the spokesperson from each centre, perhaps? Thank you. So I can see one yes. Tolu, is that still the form you're using? Janet, is that the form you're using, the one that I was just showing?
It's still the form we are using, Mom.
Good, thank you. So that one is familiar. We're using that one, yes?
Yes.
Yeah, excellent. Thank you. So if I can just ask you the same thing about the bladder pressure measurement form, is it still this one that you are using? Does that look familiar to everyone? That the form for recording the bladder pressure measurement?
Yes.
Little modification.
I'm making use of it.
Yes.
Yeah, so we still have the same forms there that are used. Okay, and do you have a form? So those are the ones particularly that we have shared. Do you have a way of recording an assessment each time that you see the child? I'm just going to share one more, which is really a list. It's not a proper form yet, but if I show you this one. Sorry, I'm just finding it. I have lots of things open on my laptop. This one. Okay, so this is the kind of information that we would like to be collecting on each child. So the first part, just the dates that catheterization was first taught, the date of the first bladder pressure measurement, the date of starting oxybutynin if it's in use. So, but then on each child, every time we see them, then we record some data, which should be, if we have a good form, this would be very quick for you to collect. But just so we are recording the size of catheter used, if we give them a new catheter, when is the next catheter due, how often they're doing their clean intermittent catheterization, their CIC, have they filled in the chart and brought them with them? And then if we take the information from the chart, the minimum and maximum amounts that they are voiding and getting through the catheter, and we can calculate the average and how wet they are. If we have all this information every time we see them at clinic or wherever we see them, then we can compare data over time, and we would hope to see that there's less wetting and more urine coming through the catheter. And if bladder pressure measurement, when did we last do it? When do we next expect to do it? If they're using oxybutynin, what dose? Have we given them a supply today? When do they next need a supply? That's all the kind of information that we would need to record. Now, and then a similar form to fill in about bowels, although for bowels it's less, there's much less that needs to go on the form. What I would like to know is, have you already got a way of recording a bladder assessment like this with all this kind of information? Or, and if so, is that the same form that every facility uses? Or if I put together a form that looks like this, do you think you would be able to use that one? So I'm going to stop sharing so I can see people. Mrs. Adewale, you've got your hand up. Would you like to unmute and tell us? Yes. Would you like to respond?
Yes, thank you, Brenda. I just want to say that this information look like the one on Shine passports that we are using for them. It's only the obtaining part that I think the form is not with me, but I think it's not really there comprehensively like this. So if you bring up form like this, it will not be difficult at all, because we are used to the kind of this same modality.
Yeah, so the I think the ship passports, as you say, capture the basic information about the size of catheter and things, but I don't think there is space in there to get the continuous, the assessment every time. But correct me if I'm wrong, Afolabi, you will know what's in the ship passport. Adewale Kahinde, no, that's in the waiting room. That's not somebody with their hand up. Would somebody else like to respond? About the form, the type of assessment I just showed you? Mrs. Oche, lovely.
Hello.
Hello, Mrs. Oche.
Thank you, Brenda, for the breakdown. We would like to have a form like that. If you can format it, we'll fill it at each visit. It will go a long way to giving us the detailed information that we need in case we need to do research into the cases. It will be beneficial.
Good. And if I produce put the information that I was showing you, if I put that into the format of a Word document, then it could be available on paper, or would people have the facility to fill that in online on the computer, or not? I don't know if Afolabi, you may be able to answer that.
Yeah, Brenda, I think, is it something I can go on Google Form?
Because the reason I am asking is because I think from Shine, somebody will be able to provide us perhaps with an Excel spreadsheet that we can input the data. So if everybody is filling in that form on every child, we can collect all the information together. But in order to do that, is somebody going to be able in Lagos to put the information from paper forms onto the computer? I just want to make sure we have the mechanism to do that.
Yeah, I think it's something that is doable. But the challenge I'm thinking about now is if we have data from LUT, from OAU, from UCH, we're not at the same location. Is it something that every facility can, maybe a portal that every facility can open and go there directly and fill in their data, rather than, because how do we get the data from each facility for each child, then for the person in Lagos to centrally impute this data into this online form?
So it would be much better if each facility can input their own data, yeah?
Exactly. Then we can have a short training. Each facility can select maybe an average of 2 persons. Then we can train them on the usage of the form, and I mean that way we can have each facility go in and input their data.
Yeah. So I think if I produce a form like we were just looking at, if I produce a form that can be printed so that it's easy for people to use in the clinic when they see a child, they won't necessarily have the computer available then. So we have something that could be printed in paper And then if we have a mechanism so the data can be taken from those to input into a spreadsheet, perhaps then each facility can say once a month they update the spreadsheet. It doesn't need to be done every day, yeah, but we need to collect the paper forms for the whole month, and then whoever is responsible should input the information monthly. Does that sound like something we can do?
Yes, it's doable. Yes,
Yes.
it's doable.
Yes, we can.
Yes. Yes, we can.
Good. Thank you very much for your responses, Mrs. Oj and Janet. If anybody has any questions about what I'm suggesting or any more comments, please just say so now, so that I can make sure I produce you something which it works for you. Yes, Chinenye, is that your name or?
Yeah, that's my name, Chinenye.
Thank you.
Thanks so much for. Thank you, Ma. I'm so grateful to be here to listen to your voice again. Please, concerning the form you are speaking about, it's very important for us to have it, but the challenge I think we might have due to technology-wise, it's supposed to have a central point where each hospital can impute it in a computer so that at the end of the month, it will be collected. But as it is now, we're in different states in Nigeria, and collecting with each other will be a difficult stuff for us. So if we have it on a sheet of paper, it will be very better as in printed out, so that each patient we see, we give it to the patient and fill it. But the issue is, how do we collect it, all the hospitals together? Is there going to be a central point where such will be done? Or is it each hospital have to travel to Lagos to submit it?
Would you have access to a computer so that you can put, so if you have the printed form for when you see the child, then would you have access to a computer so that you can fill in the information?
No, ma'am, I don't have access.
Hello, Brenda. Hello, Brenda.
Yeah.
Yeah,
Yes,
I think probably we need to re-explain what you said before. What Brenda has mentioned is that you see a child in the clinic, you have a paper format where you record the data, and somebody will be designated in your team at the end of the month, take all these paper records and impute into the portal. Probably the online portal will be designed in such a way that each facility will have a code to enter their own portal. We cannot have same portal for all the facilities. So if the portal is designed in such a way that each facility has a portal, has a code that can take them into their own portal, they can easily update their records. Then those different portals will still lead to the central portal, which only FFF and Shine can have, access to. That they can now collate the different, data from different facilities. So you still use the paper format while you see patients. Yeah. But somebody in your team at the end of the month take all these papers and update your records on your own online portal.
And the online portal will be designed so that it will be easy to do. You don't have to type lots of words. Just go to, for each child will have a record, and then with probably a record number, and then you just input if you've seen them, and if so, what size catheter. You just put a number. Yeah, what amount they're draining. You just put a number. Yeah. So Mrs. Adewale, would you like to? You have your hand up. Would you like to?
My question has been answered alongside the explanation. Yeah, and Mr. Fajemi's explanation.
Thank you. And Tolu, you have your hand up.
Yes, the question has been answered. But what I want to ask is about the ship booklets. There's a space in the SHIP booklet, where when the patient comes for follow-up visits, you write about the care, the things you do for the patient. If there any complaint, are we still going to be using it? That side of the SHIP booklet.
Yeah, I think that the SHIP booklet is something that the family keep, I think, yes?
Yes, but anytime they are coming for their catheters or for their follow-up, they bring it along.
Good,
They
good.
bring it
So
along and we fill it.
sorry, Mrs. Abiwale.
I said they bring it along to the clinic and we fill it.
Excellent. So the difference is simply that the SHIP passport is information that the family keep and take with them, but the what we are would like to collect is information for you as a service to keep that we can then collect together. So we have information on all the children. So we need to be able to count the numbers of children and to demonstrate the difference. So it's slightly different. So yes, that does mean that when you see a child, you have to fill in two things. You put in the SHIP passport and also fill in the paper form. But I will design it so that it is quick and easy to fill in, just filling in the numbers. If that sounds okay to everyone. I know that makes two things to fill in, but I think in order to secure ongoing funding and to report back on this funding, I think we have to do that. And Mrs. Olanreweju.
Thank you, Ma. Concerning the intake and output chart, is this something new to us in UCH? Although I'm thinking this can be used for the patients on the ward because of the time of charting, the time and everything, which can be used when the patient is still on admission. Although for the bladder pressure measurement, there is no problem. Looking at the form the way it is, there is no problem in filling it. But the intake and output chart, I don't think it can be given to the mothers because asking them to fill it, they might not be able to take the appropriate record of it because it's from 7 a.m. to 10 p.m. But while they are on the ward, we can monitor and we can be able to rise. So
okay, so thank you for that. So maybe what we need is I will write some basic information to go with the input output chart because they don't have to write down something for every hour through the day. It's just a chart so they can write when the child is catheterized, they should measure the amount of urine and fill it on the chart, whichever is the nearest time. Yeah, so and we need to know when they are at home how much urine they drain, how much liquid do they drink, etc. That information is necessary in order to be able to do a proper bladder pressure measurement, but also so we can show the difference it makes. So I don't know, Mrs. Ojo, you can probably, or maybe other people can also answer, are we still giving the families the bottles marked like with the 50 mils? Are you marking the pop bottles, the soda bottles, so that you can give them so they have something to measure the urine?
Yes, we do.
Yes, we are still doing.
Yeah, good. So as long as we give them something so they can measure the urine, then they ought to be able to measure. It may be that we need to make the input output chart either make it more simple or for me to just write some instructions to how to fill it in, because it doesn't mean they have to check something every hour, and they can fill in that form on a day when the child is not at school, so because they can't collect the information then. So yeah, I think we'll I'll do some instructions to go with the charts.
thank you.
Any other questions or comments?
Comments?
Yeah.
I may add some.
Okay.
The parents have
Hello, Mrs. Oye, can you please hold on? We'll come back to you. Mrs. Adewale, please.
Okay, thank you very much. I want to say that concerning that intake and outreach chart, I want to say the format that we follow in our center. I'm familiar with the chart that you showed us because I was there in 2017. But since then, what we do is that we have an exercise book. Initially, we started with paper, but now we've moved to an exercise book, like 40 leaves. So each day they write the date, they write the time, and the volume of the urine that they drain. And because it's a size book, it's not too voluminous for them to carry. When they are coming for catheter, they used to bring it. We encourage them to bring it so that we are sure that you are doing it. And they have records of weeks up to months, and that exercise book can still even contain more. I know some of them have exercise books that contain record of 3 months. I've seen them when they bring it to clinic. So if we now use this paper, is it not going to be voluminous? Are you going to design it in such a way that it look like a book? Or should we continue with that book? Should we continue with that that they use their own biro to write? They used to write date, time, and the volume of urine. That's the report. That's the 3 data in that exercise book. And it's very catchy, something they can just put in their bag when they are coming. So if you use this paper, will it not be voluminous for them, or will it be designed in such a way that it will be handy for them to go to clinic?
I think what you are describing sounds perfect. You have a very good system, so that's good. I think what we need to make sure is that for each child we have a record. They don't have to record every day, but perhaps it's better for you're working with the families, so so perhaps it's better to say write it down every day. But what we need is on the then when they write down the volume of urine through the catheter, we also need them to say if the child is wet or dry, and if they are able to pass urine normally, then can we measure that as well? So it's a little bit so rather than just the catheter volumes, in order to be able to say the catheters and the oxybutynin are making a difference, we need to see what it changes in the amount of urine they pass normally, changes in the amount through the catheter, and changes in how wet they are in between into the diaper, or perhaps they are dry. So if we can make sure we have that in the exercise book too, but it may be that we can print. I mean, at Afolabi, you would have to print it locally, but if we designed it in a booklet, like Mrs. Adewale is suggesting, that we can give them a booklet so it's like an exercise book, would just to get, is that something that could be printed quite cheaply locally, or is it better to just use a regular exercise book?
Hello, Brenda.
Hello.
So I think the idea shared by Mrs. Adewale from OAUTSC is a good one. I think we can adopt that, because exercise book is still, affordable for families, and it's very handy. You can put it in their bags on the day of the clinic. I think it's something we can allow parents to do on their own. So if it's okay by other facilities, Mrs. Oji, can we hear from you? And Mrs. Olarewaju.
Here in UCH, we have been encouraging them to use the exercise book because it's very handy, they can handle it. And with this one that is being designed now, they can easily pour urine or water can pour on it, and whatever that is written on it can easily fade up. But if it is exercise book, they can keep it and it will take care of it, and it will enable us to glance through. Although we have a challenges, because some of the patients, I mentioned about a patient that was in this with Ms. Oyelaki Kutam, 12-year-old GSS student. the mother said that the girl used to have the urge, that because I asked about the recording and she said she has not been taking the proper record of the intake and outflow because the child boils at time on his own, but before he goes to school, she will do it and in the night. So in that situation, if the girl use the toilet, it might not be able to quantify the amount of urine that is passing for the whole 24 hours. But we still have to encourage, because if the girl can void on his own, I think it will be better. But if the mother is now doing it for the morning and evening, at least it will help in emptying the bladder without retaining any urine during the morning and in the evening.
So is at the moment, is anybody measuring what the voids when the child is able to pass urine by themselves? Are we catching that and measuring that as well as the catheter volumes?
That is what the mother said. You know, it has been like 2 years that she has been to the clinic. I met her for the first time this week. You know, she's an old patient of this hospital, and because we didn't start the CIC, the program, so I think she went to Ife, like was it not 2 months ago, before they now refer her here back to UCH that we've started. So, but I encourage her. That's what she told me. I'm just trying to pass it across, because I asked about the chart and she said she has not been doing that for some time now. So we encourage her that she needs to start doing it. Although the child will go to school, and in that situation, you know, the child may not be able to take the appropriate measurement. And because she's 12 years old, you know, she's growing up and she's taking good care of herself.
Yeah, good. Thank you. So I think for each centre, what we need to say is that it doesn't really matter whether you use the input-output charts or you use an exercise book, but you need to be able to find the voided volumes, as it says here. In order to fill that in, you need to know what the biggest amount, the smallest amount, so you can calculate the average. And you need to do that for the voided volume, so that any urine there they pass naturally, as well as for the catheter volumes and the wetting. If we only have the catheter volumes, then we are only getting part of the picture. So we need, but how you collect this information, I think, is up to you. But you know, whether it's exercise or fill in charts, that information about urine is necessary. So I've suggested here that it's from the charts, but I can put in there or exercise book or whatever it is. But that's the important thing, is that we are not just getting catheter volumes, we're getting all that information. And we should be able to look at that information in conjunction with how much they're drinking. Because if we see that their volumes are very small because they are wetting a lot and their diapers are soaking wet, or is it because they are not drinking enough in the first place? So that's why we like to think, when we have the chart, it is on the same chart, we are able to compare the amount that they drink with the amount of urine that they pass. That's the reason for having it all on one chart, because then we can work out if they are have very small volumes of urine that they pass. Is it because they are drinking, not drinking enough? That's the idea. That how you collect this data, I think, it can be different from each centre. It can even be different for different children, because you know your children, yeah. As long as you have the data to fill in this kind of thing on the assessments. I hope that makes sense. Does that make sense to people? Yeah.
Yes.
Yeah. Hello, I can see you nodding. Yeah, and Mrs. OJ, thank you. Yeah.
Yes. Just wanted to clarify something. Now for the form, they don't have to fill it early. They take the time.
Sorry, I'm going to interrupt Mrs. OJ. Tolu, I think if you mute, then I think Mrs. OJ will not echo, I think. Thank you for the comment in the chat.
Okay. thing about the chart that they don't have to go strictly with the timing on the chart. It's the time the child voids. They pick out of the time there and record. Because somebody was saying, how can they cope with 7 a.m.? No, it doesn't have to be exact time on the chart. It's the time the child voids.
That's exactly right, Mrs. OJ. The times are really, they are trying to make it easier to fill the form in, so that when the child does a catheter, if it's 9 o'clock in the morning, they just find the 9 o'clock in the morning line on the chart and write it down there. You're absolutely right, Mrs. OJ. But it may be that some people find the format of the form complicated. So I will think again about making it as straightforward as possible. Okay, do we have any other comments? Or any other questions? Nope. Okay, I think I thank you for your feedback. I think I have enough information to design the forms, which I will then share with Afolabi to share with everybody to make sure that that everybody is clear about what we need to do, and then we can. I am sure that Kate will be able to get somebody in the Shine office to do some nice spreadsheet so we can just easily input the information once a month.
Yeah, I'm sure it won't be me, but I'm sure I can find somebody who knows what to do. So yeah, we'll
Thank you.
Sorted.
Lovely. Okay, I think that's everything I would like to ask for and discuss for the moment, Afolabi, if that all makes sense to everybody.
Thank you very much, Kate, Brenda. Yeah, it's been a very interactive session, and I hope we've learned together on all sides. So our time is fast, but we've gone beyond the time slated. So I want to apologize to everyone. We really want to appreciate your time. But quickly, I would like to share some updates under AOP. Number one is that under the new grant, we're going to have some incentives to encourage healthcare professionals across all facilities. And I would like to appreciate Kate for that. We proposed it, and she welcomed it, and also proposed to the donor, which has been approved. So for all our trainees and the working group meetings, so we'll be supporting participants with data to the tune of 1,500 naira. We also be giving out honorarium for your time at all our trainings and the working group meeting at the tune of 4,000 naira. So in terms of reaching out to families, from the past reports and even the present, today's report has been seen as a challenge for all the centers in reaching out, following up with the families. So the Shan has also graciously approved the sum of 3,000 naira to each center on a monthly basis to reach out and follow up with families. The only thing we have to do here is your team, each facility has to appoint, I don't know whether it's going to be the focal person that we do this, or the focal person would like to appoint another member of the team to do this. So, which means that whoever is getting this resource is going to be following up families that receive this care in your center. Don't forget, when I was presenting, sharing the overview of the grants, I mentioned on that the project officer will also be following up at least 50 families, visiting them at home to ensure that what they have been taught is being done, and to let them also understand the importance of continence care management in the life of the child. So I think that's a good one for all of us. Thank you to Kate for approving that. One other last thing I would like to share with us, and I want us to share with families, is that I went back to the reports submitted by Brenda's report after 2017. And in that report, she indicated that in that report, she indicated that some of the children, I think about 7 them that were seen on the first visits are already showing signs of kidney problem. And we have seen that in one child by name of Bayemi Samuel, who has been hospitalized last more than a week now. And it was, kidney failure was, kidney infection was diagnosed, and it's hard for dialysis as of today. Was discharged, was it yesterday? No, 2 days ago. It's been seen at Redeem Health Center at the Redemption Camp. I think the reason why they went there was because the religious body has the GO, but they have a dialysis machine, I think last year. So probably they thought they have gone to the public facility, because I was asking, telling the father when I was in the UK that why didn't they go to Lutz, where you received, runs clinic. So probably they are thinking that they might have to be on the queue. I don't know the number of machine that I have in use at the moment. So why I'm sharing this is that we still need to impress it for the parents, the need for them to take this program seriously, and to see the clinic as the way they see neuro clinic, because everybody believes it's just once the child attends neuro clinic, it's all over. So please, we can share this story with them. It's not something that I want to see in the lives, happening among our children. So we have a lot as parents, we have a lot to deal with, not to be, the child to be experiencing, bladder or problem, in addition to other challenges. So I'm just sharing this so that we do more to share, raise the awareness, share awareness among parents, and also let them see the importance. So thank you very much, everyone, for your time. It's been a good day. So, and I believe that, so for as regards training, the 2 trainings, what we discussed in Cardiff last week, was that based on the time for Brenda, we're proposing June for the online training. For some of us who have attended, who have had the training, all of us here have had the training, but just for us to, refresh our, knowledge. Then, like I did mention during my presentation, we have other facilities, precisely River State University Teaching Hospital, University of Abuja Teaching Hospital. Also, they showed interest by themselves. University of Benin teaching hospital. These 3 facilities are coming on board. So we want them to be in that training, but at the moment, we are trying to advocate to those facilities, the authorities, reaching out to the authorities for their buy-in and also cooperation in the program. So we hope that before June time, the authorities in these facilities will have, keen, then we can all have the training together. Thank you. So before we wrap up, please, if you have not put type your name in the chat box, can you quickly do that so that we use that for our attendance? So, is there any other comments, questions? Question, comments before we close? So although I've taken one picture, but if we can put on our videos so that we can see our faces again, and can we all put on our videos